Dentin hypersensitivity is one of the most commonly encountered clinical problems, also known as tooth sensitivity or dentin sensitivity. Clinically described by Holland et al. As an exaggerated response to application of a stimulus, either thermal, chemical, osmotic, or tactile, that cannot be ascribed to any other dental defect or pathology. Dentin hypersensitivity and dentin sensitivity, these terms can be used interchangeably, and true hypersensitivity is described as one that develops due to pulpal inflammation and can present the clinical features of irreversible pulpitis. Presents itself as severe persistent pain as opposed to the typical short, sharp pain of dentin hypersensitivity. It can affect patients of any age, most commonly 20 to 50 years of age group, associated with canines and premolars of both the arches. Specifically, buccal aspects of cervical areas of these teeth are affected. When we talk about dentin itself, it itself is a vital tissue. Dentin is covered and protected by enamel in the crown portion and by cementum in the root portion. There's three important terms to keep in mind to understand dentin hypersensitivity. That is dentinal tubules, odontoblastic extensions, dentin pulp complex. Dentin is considered vital due to the presence of dentinal tubules that are naturally sensitive because of odontoblastic extensions and formation of dental pulp complex. Both dentin and pulp, although are histologically different, embryologically derived from the same precursor, that is ectomesenchyme. Odontoblasts constitute a single layer of cells on the surface of the pulpal tissue just below the predentin. At the end of the cell is the odontoblastic process. This process extends into the dentinal tubules and generally terminates at about one-third the distance between the pulpal chamber and the dentino-enamel junction. Dentinal tubules, as the name suggests, are small canal like spaces. The sharp pain of dental hypersensitivity is due to the flow of fluid through the open dentinal tubules into the pulp of the tooth. Much has been learnt about dentin hypersensitivity since it was first documented by Blum. Three main mechanisms of dentin sensitivity that have been proposed are direct innervation, natural theory, odontoblast receptor or theory, fluid movement or hydrodynamic theory. Direct innervation theory is one of the early and most obvious hypotheses which state that dentin is innervated by nerves and therefore whenever any stimulus is applied to the dentin, nerves are directly triggered and elicit a response. This theory is no longer widely accepted as later evidence from electron microscopy revealed that nerve fibers do penetrate the dentinal tubules but only for a very short distance into the inner dentin and mainly over the pulpal horns. Next theory coming to odontoblast receptor or transduction theory. Odontoblasts constitute a single layer of cells on the surface of the pulpal tissue just below the predentin. At the end of the cell is the odontoblastic process. It was assumed that odontoblasts act as receptors of pain and transmit signals to the pulpal nerves and indirectly cause dentin sensitivity. But this theory has also been rejected since the cellular matrix of odontoblasts is not capable of exciting and producing neural impulses. Furthermore, no synopsis has been found between odontoblasts and pulpal nerves. If you look at this picture, you can appreciate a space between the odontoblast process and the tubule wall filled with dentinal fluid. Currently, the most widely accepted theory is the hydrodynamic theory by Branstorm. The theory states that sensitive dentin is based on the stimulus induced fluid flow, that is, any stimuli, be it thermal, chemical, osmotic, that acts on exposed dentin, creates an increased dentinal fluid flow. And this displacement of fluid within the dentinal tubules result in nociceptor activation, causing the characteristic short, sharp pain of dentin hypersensitivity. Causes of dentin hypersensitivity. For dentin hypersensitivity to occur, the dentin surface of a tooth must be exposed, that is, lesion localization, and This can occur due to hard tissue loss. That is, exposure of dentin could be either to loss of enamel, which includes attrition, abrasion, erosion, or soft tissue loss, that is, gingival recession, exposure of the root, that may be due to aberrant anatomy, orthodontic tooth movement, poor oral hygiene, bleaching, etc. This lesion initiation, that is, presence of open dentinal tubules in combination with lesion localization, that is, pain and dentin sensitivity. As like any other medical condition, an accurate diagnosis is important before starting the management. It starts with thorough clinical history and examination. A diagnosis of exclusion or by exclusion is a diagnosis of a condition reached by a process of elimination. Dental hypersensitivity is rapid in onset, short in duration, and sharp in character. Although it has features which are similar to other conditions like caries, fractures, or chipped enamel or dentine, pain due to reversible pulpitis, and post dental bleaching sensitivity. Some other techniques include pain response upon pressure tapping. If yes, it may indicate pulpitis or periodontal involvement. Pain upon biting on a stick may indicate tooth fracture, which may be confirmed by using transilluminating dye or light. And check for any recent restoration, any micro leakage, or high points. A simple clinical method of diagnosing dental hypersensitivity includes use of three ways: air or an exploratory probe on exposed dentin in a mesiodistal direction, examining all the teeth in that area which the patient complains of pain. Radiographs, evaluation of occlusion. The severity or degree of pain can be described either by categorical scale, that is, slight, moderate, severe, or by quantifying it using a visual analog scale.
Hope this video was helpful. Thank you so much for watching. Do like, share and subscribe to the channel Dentistry Unfiltered.